Iron is an essential trace element that plays a critical role in oxygen transportation, energy production, and cellular metabolism. Because we lack a regulated mechanism for iron excretion, the iron balance has to be maintained primarily through careful control of absorption, transport, utilization, storage, and recycling. Iron enters the body through the diet in two principal forms, heme iron and non-heme iron. Heme iron is derived from animal sources such as meat, liver, and fish, where iron is bound within the heme moiety. Non-heme iron, on the other hand, is obtained mainly from plant-based food, including cereals, legumes, and green leafy vegetables, where the iron exists in an inorganic form. Although non-heme iron constitutes the majority of dietary iron intake, heme iron is absorbed more efficiently. That is because the bioavailability of non-heme iron is influenced by many dietary factors. If you have vitamin C in your food, it would enhance iron absorption, whereas presence of phytates and tannins would do the opposite. Iron absorption occurs primarily in the duodenum and upper jejunum. Non-heme iron must be reduced from the ferric form to ferrous form before its absorption. This reduction is facilitated by gastric acid and dietary reducing agents such as ascorbic acid. Ferrous iron is transported across the intestinal mucosa via specific transport proteins. Once inside the enterocyte, iron may be temporarily stored as ferritin or transported across the basolateral membrane into the circulation. In contrast, heme iron is absorbed intact through a separate transport mechanism and is less affected by dietary inhibitors. Iron has two identities in the body: ferrous, the biologically active worker form; ferric, the storage and transport traveler form. After absorption, iron enters the plasma where it is immediately bound to transferrin, a glycoprotein synthesized in the liver. Transferrin binds to iron in the ferric state and serves as the principal transport protein, delivering iron safely to tissues while preventing free iron mediated oxidative damage. Only a very small fraction of total body iron circulates in the plasma at any given time, but this pool is metabolically very critical. Iron is associated with two main proteins in the body: transferrin, the taxi, which safely transports iron through blood, preventing oxidative damage, and ferritin, the volt, intracellular protein that stores iron in the liver, spleen, and bone marrow. Both of these proteins are associated with the ferric form of iron. The majority of circulating iron is delivered to the bone marrow, where it is utilized for hemoglobin synthesis during erythropoiesis. Iron is incorporated into heme, which combines with globin chains to form hemoglobin, enabling red cells to transport oxygen efficiently. Iron is also taken up by muscle for incorporating into myoglobin and by other cells to be used in cytochromes and iron-dependent enzymes. The recommended daily allowance for iron can vary significantly across different demographic groups. Adult men have lower iron requirements due to their minimal physiological losses, whereas menstruating women require higher intake to compensate for their menstrual loss. Pregnant women, on the other hand, have the highest iron requirement due to expansion of maternal red cell mass, fetal growth, placental needs, and anticipated blood loss at the delivery. When iron intake or absorption fails to meet physiological demands, iron stores can become depleted. This can lead to impaired hemoglobin synthesis and development of iron deficiency anemia. Conversely, excessive iron can accumulate due to increased absorption or impaired regulation that can result in iron overload. This can lead to toxic deposition of iron in the tissues. Now let's see how we investigate the iron status of a patient. The laboratory assessment would involve measurement of serum iron, ferritin, total iron binding capacity, and transferrin saturation. Serum ferritin would reflect the body iron stores, and it is the earliest and most specific indicator of iron deficiency. Then serum iron would represent the circulating iron bound to transferrin, whereas TIBC provides an indirect measure of transferrin concentration. Transferrin saturation, on the other hand, is calculated from serum iron and TIBC. It indicates the proportion of transferrin occupied by iron. An interpretation of these parameters together allows differentiation between iron deficiency, iron overload, and you should not forget to interpret these with the clinical context and the inflammatory status of the patient.